that introduction. Thank you. We'll go ahead and get started. Our speakers today have no relevant financial disclosures to give today. Our learning objectives for this session is to summarize key themes and trends in state laws supporting pharmacist payment for services. So we'll give a broad overview of some of the things we look at as we think about state trends, discuss how these laws affect pharmacists' ability to bill for and deliver patient care, and identify effective policy elements that can be applied to expand pharmacist reimbursement in participants' own states. So some tips for all of you in your advocacy efforts. Next slide. Definition. So we landed on highlighting these 4 words for definitions, but there's many other words related to payment for clinical services that come up as well. So first of all, payment is really a broad term. So payment encompasses all forms of contractual, team-based, or prospective payment models, could include value-based care and value-based care arrangements that a clinician is paid for. Reimbursement tends to be a little bit more narrow. It's payment for a particular service based on charges submitted and reimbursed by payers. So reimbursement's a more narrow term. Credentialing. So credentialing is the application and submission of required documentation and the approval of that submission to be recognized as a provider by a health plan. Credentialing can also be done within a local health system. So a clinician may be credentialed to provide services within the health system. But that is usually completely independent of what the plan thinks about whether or not you're a provider that would be paid for services. So think about credentialing at the local level, but today we're talking about the payer level. There's also a term called enrollment. In some plans will enroll providers. It's usually a quicker step into the process to enroll as a provider. There's less background checks kind of things than what is involved in credentialing. Credentialing also has specific accreditation standards that plans are accredited for their credentialing processes, and enrollment would be more of a plan-specific process that's established. And then payment parity is the principle that pharmacists should be compensated at the same rate as other healthcare providers. So some state laws have written in that there should be parity for pharmacist payment. In other states, required coverage for services doesn't necessarily link to parity. So it's still leave it up to the plans of what they're going to pay for said service. So next slide, please. Yeah. So really, we're all here together because we were a part of this Advancing Pharmacist Payment Parity work group led by Dr. Jonathan Hughes, who led this publication, and we are currently working on updating it as things change quickly. I know my state changed from 24 to 25. And some of the highlights from this paper is that there's inconsistent and insufficient reimbursement. And because of that, it really minimizes the pharmacist's ability to be fully integrated into the interdisciplinary or interprofessional care team. And that inconsistency can make it difficult to build a practice when you have multiple plans or payers who cover your patients, and every plan's a little different or the coverage is different across your patient population. We also know that progress at the federal level is exceedingly slow. And so sometimes we can make quicker changes at the state level that can really impact what we're doing locally at the state. We don't have to wait for those federal changes. Next slide, please. So a few words on provider status. And a key point to remember is that provider status is not the same as scope of practice. Pharmacist scope of practice is defined by your state, and that includes prescriptive authority, what you can do in terms of immunizations, all these things that are about your scope that really say you can do these things, but a scope of practice doesn't say what you could be paid for to do these things. Provider status is more about do the payers recognize the pharmacist as a provider that is able to be paid for services. So if we start at the top, there's Medicare provider status, Medicare Part B. That requires federal legislation to have pharmacists included into Part B. Right now, the ECAPS, or Equitable Community Access to Pharmacy Services Act, is in Congress, and that would add pharmacists to providers in Medicare Part B for testing and treatment and immunizations. So targeted services. So that would be a win, and that's under consideration in Congress now. At the state level, the state governments regulate who's considered providers within state Medicaid plans. So state laws can require certain coverage of services within a state Medicaid plan. Sometimes that's regulatory, sometimes it's statute, depends on your state and how their Medicaid plan is set up. And then a commercial plan decides what they want to do. So you can have laws that mandate certain types of coverage for a commercial plan, but a commercial plan can also choose to do what they want. And that's an important thing to remember as we're targeting expanded coverage for pharmacist services. That commercial plan space is a place to target locally that you don't necessarily have to wait to get state or federal legislation passed. So provider status is important, and it's important to understand those different payers and how we interpret provider status. And with that, I will turn it over to Dr. Lingo.
All right. Thank you, Dr. Westberg. So I really like this image. I will admit it might be a little bit outdated, but it's from APHA's website. And I think it just kind of shows visually the variation in pharmacist payment throughout the states, right? So you can see that some states have Medicaid coverage or parity. Some states have commercial payment, and then some states don't have any, some states have both. So I think the purpose of this slide is, first of all, try and find your state and see if you're not sure what the pharmacist payment is in your state. This might be a helpful place to start. And also making sure that it's accurate. As Dr. Westberg said, things have changed from when we initially wrote that paper to now. And so things are constantly changing, which I think is a good thing, but also important to kind of keep up as providers in these states and just kind of make sure that we're always able to practice at top of license. Next slide. All right, so this comes directly from the State of the Union paper that we mentioned earlier. So in that paper, we identified 36 states with some sort of legislative or regulatory support for payment. I will point out that there are some states that have pharmacist payment that actually don't have legislation. So Dr. Jones had mentioned that in Arkansas, where she practices, there is a commercial plan, Blue Cross Blue Shield, that has kind of volunteered to reimburse pharmacists for some of the work that they're doing, but it's actually not in legislation. So I think that's another kind of nuance to keep in mind. But of the 36 states that have some sort of legislation, there are 16 that have established Medicaid payment, 13 with commercial coverage, and then 4 mandated payment for narrow scope. So for example, Rhode Island has kind of a narrow scope for specific disease states, if you will, so like hormonal contraception and the HIV PrEP and PEP. So pharmacists kind of have payment for those things. And then there are some states with full parity. So I will use Oregon as an example that has full parity for both commercial and Medicaid reimbursement. Next slide. So kind of some themes or takeaways for pharmacist payment throughout the nation. We're making progress. So there are several states with provider status, and as Dr. Westberg mentioned, that of course is a good thing, but even any form of payment for pharmacist service is a win. Obviously, we are not identified as providers at the federal level yet through CMS, but some Medicaid plans and commercial insurers are reimbursing more. But as kind of that map identified, and one of the big themes of our paper is that there is still inconsistency among the states. As far as scope expansion, some things that states are doing is implementing collaborative practice agreements. In my state, they're called, I practice in Missouri, they're called medication therapy service agreements. So basically the same thing. Some are more vague and can cover a multitude of disease states, and some are very disease state specific. There are test and treat legislations. So kind of like we talked about and what's being proposed with ECAPS. And then really just a shift from the scope of practice to standard of care. So kind of identifying pharmacists as providers or, important players in the healthcare team as part of standard of care rather than just identifying very, specific things that we can do as far as scope of practice. PBM reform is really big right now. I know my state has several active legislations or active bills calling for fair pricing of medications because this can be a really big hindrance, especially for pharmacists practicing in the community setting. So calling for fair pricing transparency and reimbursement stability. I believe there's even some federal legislation happening right now as far as PBM, reform and transparency. So that's happening. And then other federal movement, so just increasing advocacy around Medicare coverage that's underway right now. And then as Dr. Westberg mentioned, that the ECAP, so for kind of those specific disease states and vaccinations and things like that. So these are the themes that we are seeing as far as pharmacist payment throughout the country.
And we'll talk a little bit more about that scope expansion that Dr. Lingo brought up. So she did briefly mention these collaborative practice agreements or CPAs, and they go by different names as she mentioned. This is just a general name that all of them kind of go under. But regardless of what you call it, it's essentially a legally binding contract between one or multiple providers and one or multiple pharmacists within the practice. And it provides framework for the who, the what, the when, the where, the why. So which pharmacist, what patients can pharmacists see, what services can they provide, what's considered within their scope when they're practicing here, and what's considered outside of their scope when a provider needs to get involved. The CPA can be used to elevate the pharmacist role to be able to bill for specific services they are providing. But unfortunately, there are some tedious parts to it, some barriers. Depending on the state, the credentialing pathway can vary. So it can sometimes be frustrating to figure out, depending on which state you practice, how can you go by getting credentialed? Is it just filling out a simple application, or do you have to do an entire certification? You also have to consider resources and oversight. Do you need to have a provider available in the clinic at all times? Or do they just need to be, available in case of emergencies? Do you have the space to be able to see these patients? And then, of course, advocating for your services within the clinic as well. All of that takes time and effort that you have to account for. And then lastly, you have to consider, even if you can get reimbursed, what does that billing look like? Is it sufficient to maintain the practice? So all of this needs to be balanced and work through in order to determine, how to go about getting the CPA and how to go about getting reimbursed for these services. And next slide. And so, as mentioned before, there are some states that have been able to accomplish this payment parity, where pharmacists are, not discriminated against and seen equal to any other healthcare provider in terms of billing for these services. We have some states listed here. So, for example, Maryland states that they will cover all services provided by pharmacists. Oklahoma and Oregon find that it listed that no restrictions as long as it's within the scope of practice. And we do find that when parity is accomplished, in the beginning, it is a little vague, and there is minimal guidance to the extent of services provided, what billing codes to use. And for example, it says, there's no restrictions as long as it's within the scope of practice. What is considered within the scope of practice? So it does take time to work through all of this and figure out, exactly what services we can provide and what we can bill and how can we bill. And the criteria vary as well in terms of how you can be deemed a provider to be able to bill for this. So for Maryland, you just have to be enrolled with the payers. With Oklahoma, you have to be enrolled and credentialed with payers. And then with Oregon, as mentioned before, you do have to have a collaborative practice agreement. So depending on what the criteria is, you'd have to determine how to go about meeting that and have the time to do that as well. And the next slide. In some states, unfortunately, although they don't have payment parity, they do have scope-specific reimbursement. So we have payment parity equal to other healthcare providers for specific services, and this was briefly mentioned before. Unfortunately, they may have limited guidance or resources set up for these services. So some examples are listed there, like they could provide HIV PrEP or PEP, hormonal contraceptives, COVID and/or influenza testing and treatment, and then tobacco cessation. And so for my state, for example, in New York, you could say recently, but I think this was it actually came out when we released a previous article at that time, pharmacists were allowed to order and dispense self-administered hormonal contraceptives. It did require a non-patient specific order. And the patient needed to consent and also fill out a self-screening risk assessment questionnaire that needs to be kept on file. And the pharmacist is able to provide up to 15 minutes of services to the patient where they assess and intervene, either face-to-face or telehealth. Now, when this first came out, it did say that pharmacists can do this after completing training. What training was not entirely specified to begin with. Now, at least a year out or so, there are training programs available for these pharmacists, but unfortunately, a lot of the community pharmacists are very limited in terms of having the resources and the time to complete this training and to also be able to provide these services for the patient. So although it's nice to have these scope-specific reimbursement, unfortunately, it's not always something that pharmacists can provide on a daily basis, whether it's because of limited resources to set it up or limited resources to be able to provide it on a day-to-day basis. And with that, I will send it over to Dr. Jones.
Hello. So as we're going forward and you're thinking about your state and what we're trying to accomplish for pharmacists, it's important to consider what we're asking for so that we make sure that we're not shooting ourselves in the foot with making a request that then ends up being a limitation. So these are some of the things, and these all come straight from the State of the Union article, but these are the things that to consider asking for. So one, a non-discrimination mandate so that the legislation prohibits discrimination based on a pharmacist's licensure. It's not enough for laws to simply permit pharmacists into network. We get real sustainability when we're guaranteed equal footing with network inclusion, referrals, reimbursement, etc. If we are providing the same service, we should receive the same payment, and that makes sure that we aren't sidelined with providing clinical services. The second one would be that payment should reflect what pharmacists are legally allowed to do in each state. Because the scope of practice differs in different states, sometimes we need a CPA or protocols for the same service. So the legislation that we are working towards should require that all allowable services under the state law are covered and reimbursed at the same rate as when other providers perform them. What we don't want is to have a separate pharmacist-only fee schedule. We're looking for parity, and it simplifies it for the clinic and for the billing and for the payers as well. We don't need our own special payment. Number three would be broad applicability across the payers so that we're not asking for just one payer type. Because if you think about our patients, all of our patients have different payers, and our patients deserve access to pharmacist services no matter who their insurer is, whether it's commercial or Medicaid or beyond. So we need that broad applicability, including consideration for fee-for-service, as well as managed care organization administered Medicaid. So in Arkansas, and I saw some stuff in the chat about the Blue Cross Blue Shield, which we can absolutely discuss in the Q&A period, because there's some really cool stuff happening there. But Arkansas has also been very vocal in the PBM reform. And in 2020, Rutledge versus PCMA, so our Arkansas Attorney General sued PCMA for payment. And what came out of that was that the state has authority in regulating self-insured health plans. And so while that was really geared towards PBM reform, there may be some implications related to clinical services and not just dispensing of medication. So that's something to keep an eye on. Number 4 is using the same credentialing and reimbursement pathways. So having a separate system for pharmacists creates inequality and inefficiency, like I mentioned a minute ago. So creating a pharmacist-only credentialing or reimbursement pathway, it might seem like a solution, but it really sets us apart in a way that undermines our parity. So if we can use the same systems as physicians, nurse practitioners, PAs, et cetera, it keeps everything cost-effective and sustainable. And as pharmacists are starting to work in different clinical settings, like outpatient offices and primary care outside of health systems and independent clinics, it becomes a real logistical challenge for the billing departments if we're set up in an entirely different reimbursement pathway. Number 5 is that payment should follow, or parity should follow the provider, not the location. I know, like with immunizations, the payment is to the pharmacy's NPI, not the pharmacist's NPI. And so it's tied up there. So pharmacists provide clinical services in admitting settings, hospitals, clinics, community pharmacy, and the legislation should not restrict reimbursement to certain locations. It should be focused on our role wherever we deliver that care. Just like we have the test and treat, we have the birth control, we have the smoking cessation. The pharmacist providing that service should get the same payment, whether they're doing that in the community pharmacy or in the clinical setting. And so those 5 characteristics are kind of the benchmarks that we can use, so some flexible goals that we can use with our legislators, with our payers, to advance that payment parity. And then as we pursue those, even incrementally, our states can move closer to a more equitable, sustainable recognition of pharmacists as healthcare providers. So that is my part, and now I'm going to pass it over to Dr. Chaudhry.
Hi, everyone. So, with all that information, what can we do as a field to really work together and progress this mission together? And as you might have heard, like many states, while they're going through the process of trying to gain provider status and trying to reach payment parity, they're going through a lot of uncharted paths through this process. And at each step, there are certain barriers that can show up. And so, truly, this is really a call to action for us to really work together and disseminate key learnings and barriers that are going to make us more successful to integrating this process. So, for example, just because you have provider status does not mean that you can necessarily start billing for the services that you're providing. So each step is integral in the process. So, for example, starting at credentialing, that focuses on your qualifications, and usually this requires some amount of collaboration with regulatory and accrediting bodies. And then you move on to privileging, which focuses more on scope of practices. And then finally, you get to contracting, and this is really important to get the payment for the work that pharmacists are actually completing. And this requires collaboration with payer contracts. So throughout this whole process, it's clearly a very collaborative approach. It requires working with regulatory bodies, working with IT, board of directors, legal teams, billing, finance, and all of that's really important to know, especially when you're starting to go on this path to try to receive payment for our services. And so if we provided more webinars like this, or we had a lot of publications that talk about processes, especially for each specific state, that could help build a roadmap for other states that are going on the same process as well. And then the next thing is to focus on standardizing the processes. So, a lot of times when you start billing for these, legal aspects start getting involved as well. So, thinking about small things like documentation, and if you have multiple pharmacists at the same clinical site that are billing for services, are we making sure that we are meeting all those legal requirements? Like how much time is spent with the patient? Are we documenting the things so that those contracted payers can see that we are billing appropriately for the services that we're providing them? And so, even having those learnings, I think, can make the process a little bit easier for other people and help just create the model. And then finally, look at publishing those outcomes and performance indicators. So we can measure this through clinical, financial, and humanistic outcomes to do a practice evaluation and see what are the gaps that are needed to overcome, what are the successors, what are good performance indicators to look at the success of this, and then return on investment, because this in turn can also help fund new positions for more pharmacists. Because when you look at the scope of practice, pharmacists are adding another element alongside with the providers. We're not fighting to take over what they're doing. Rather, we are supporting them to help strengthen the outcomes of the patients. And not just that clinically, but we're also helping the health systems with return on investment. So a lot of times when pharmacists are able to bill for these services, they are paying for their own position through the billing that they're able to offer these patients. And then this way, when we have all these together, we can support other states to be more prepared for the process and hopefully be more successful. And now I'll pass it on to Dr. Muhammad.
As we kind of wrap up and think about where we have seen success, it really shifts our focus to focusing on state-based advocacy efforts that really support those federal initiatives for payment parity, especially as we found in the manuscript that we worked on, that those federal initiatives, as you all know, do take significantly more time than the state-based efforts that we have been able to make progress on across the nation. So these legislative wins at the state level really support that collective goal for provider status and parity across the nation. And when we think about some of the opportunities that exist, it's things that we all can do. Collaborating across national pharmacy organizations, which I think is something that we have as a profession been working on to ensure that we're not all working in silos. And I've also found that working with statewide pharmacy organizations is extremely helpful to figuring out what's going on behind the scenes. For example, in Michigan, looking at our hormonal contraceptive bill that has been passed and the corresponding reimbursement bill, sometimes it's very vague to know what's going on with that. Where are we in that process? But reaching out to the state pharmacy organization really helps to identify how far and how much progress we've made in actually attaining that reimbursement. So speaking to state representatives and payers, joining letter writing campaigns that already exist is valuable. And then for those of us who are, which is most of us, working with learners and trainees, as well as involved in colleges of pharmacy, really pressing this on to the next generation of pharmacists so that we don't lose momentum, so that we stress the importance of this and continue the momentum that we have already built. And with that, I'll pass it back over to Dr. Horace for our panel discussion.
Wonderful. So thank you everyone for sharing insight and presenting. You provide a wealth of information and especially inspired me to become more involved with payment reform for the state of Louisiana. That being said, we do have a question in the chat, and one of them is, how are others getting around to needing to obtain ID for reimbursement for Medicare, Medicaid Advantage plans or Medicare Advantage plans?
As a panelist member, I'll be curious if others have an answer. I'm not sure if there is a way around that if you're billing a Medicare Advantage plan, you need to be recognized as a provider through Medicare. So that is a real barrier that's current. Unless anybody else knows anything different or has been maybe be able to customize something with a local Advantage plan, maybe that's possible. But just jump up if you have a different experience than what I'm articulating.
No, I was just gonna say the same thing. I think I have not, had any success just without having the recognition or being credentialed through Medicare at all. I think it's really limited to incident to billing for patients with Medicare.
Okay. So next question. Is this still a barrier in states that have legislated treating pharmacists as providers?
Yes, because the state legislatures don't have jurisdiction really over Medicare rules that are determined federally by CMS. So it's still a barrier.
All right, so we have Starlin and she says, however, state Medicaid can.
I think that's an important point for us to make, is that because federal it's a really tall mountain that we're trying to climb federally. And so until we can do that by whatever means, whether it's national advocacy, yeah, Everest, exactly, yeah. Until then, we do have a little more influence at the state level. And so that's kind of what the value of this conversation is I can only speak to my state in Arkansas, and Arkansas is a really strong pharmacy state, but still, there's a lot of educating of our, and we have several pharmacists in the legislature even, but there's still a lot of education overall that we need to give to our lawmakers, because they're the ones who are determining the finances. So like, for example, Arkansas, pharmacists have been considered Medicaid providers in Arkansas for a few years. However, it is not built into the Medicaid manual anything for us to get paid for. So that it's actually two different pieces. So Harding University students actually wrote some legislation several years ago in order for pharmacists to prescribe smoking cessation products so that Medicaid would cover those products for the patients. So Medicaid will cover them if they're prescribed by a pharmacist, but the pharmacist does not get reimbursed for that service. So it's two flavors of problem. So we kind of overcame one, but it's a separate legislative issue to actually get the pharmacist paid for that. And that's a different set of people that need to be educated and convinced that that is worth. And speaking of, while I'm talking, getting worth it. So Arkansas Blue Cross Blue Shield voluntarily covers pharmacist services because they are dealing with like star measures and things like that. Our payments or our payers are under rules as well. And if they don't meet their baseline things, how they get money changes. And so it is in a lot of payers' best interest to have pharmacists providing some of those services. And Arkansas Blue Cross Blue Shield recognized that. And so they invited us to do this test and treat, birth control, prescribing, things like that. And they have been really fantastic. Last time I spoke to Denise Clayton, who is our contact, they had not finished collecting the data on our outcomes yet, but they were hoping to have some outcomes data to report so that you could potentially take that to your states and show that it's worth it to them to include us for those. And we're also, I think they're starting to talk about A1C testing in the community pharmacy. So have this conversation with your third-party payers, whoever they are, whether they're in the legislature and it's Medicaid or it's your commercial plans, because they may be open to a conversation.
Okay, so the next question is, some payers are hesitant to pursue payment since some ambulatory care pharmacists are already providing services without billing. How do you get around this?
It's such a good question. And I think it really highlights, um, you know, the importance of pharmacists individually saying, my service has value and it's okay to ask to be paid for the service that's valuable. In terms of payers saying, oh, you're already doing that for free, why would I pay you for that? I think there's a lot we can do to further explain and dispel that myth that the services we're seeking payment for is more comprehensive medication reviews, a deeper clinical service delivery that requires more assessment that maybe isn't actually the same as what's being given away for free. And to also note the importance of sustainability when the going gets rough, when things are busy, when budgets and financial pictures are not what you want them to be, the things that aren't bringing in income are the things that go away, and our communities and our patients suffer. So I think the more we can keep those conversations with payers focused on, we need this to be a valuable patient serving service, and we can't continue to provide it if we're not adequately, if our costs are not adequately covered. I don't think pharmacists are looking to make a huge profit on any of this. We're just looking to stay in business and being able to provide the service.
I would love to touch on that as well. So, I practice in Indiana. We do not have provider status, but I did create a co-billing model where the provider will come in with me at the last 5 minutes, and then through that model, we're able to bill. And so, what ended up happening was halfway through, suddenly patients had to pay a copay, whereas before they did not have to. And what I will say, although it is a big concern, patients who are really established with clinical pharmacists, they really do understand the value that we bring to them. And sometimes it's just like a question of technicalities that they ask, oh, before I didn't pay and now I do. What's the difference? And I think it just takes like a small explanation, like Dr. Westberg was saying, that we're trying to cover our services that we're providing, and then this also helps support other clinical pharmacists being able to provide services for more patients, and they really do respond to that well. And then obviously, when you have new patients come in, they don't know that they never had to pay, so it hasn't been a problem. And I do serve underserved patients, and I don't think I've had any patient stop seeing me because of the copay, which is really great news because we do offer really good services.
Okay, thank you. So our next question is, does anyone have resources to decrease the lift when having these conversations with each area? I find I have to do a significant amount of education with health system compliance departments, clinical committees, primary care administration, the payer, etc.
I'll just go ahead and say, unfortunately, no. I'm sorry. I think that has probably been one of my biggest struggles, or where, it feels kind of overwhelming, is because I think, we all kind of feel like we are doing this on our own. And I think that's why this group is so important, to know that, we have other people in other states who are doing the same thing. But as far as like, and I'll just speak, administration at my practice site, I think they don't necessarily like understand all that, a pharmacist can do. And so advocating for ourselves is like the only way that we're going to get this done. So I feel like, it's a whole nother thing to add to our workload, right? To try and get this recognition in our states and this payment parity with various plans. But unfortunately, I don't have a way, an easy way that that's happening besides us doing it ourselves. Increasing awareness, I would say, is the best.
One other resource that I have found valuable at times is looking at the statewide and regional organizations. I know that in our state, there often are efforts to share some of these resources that can be helpful on a kind of limited, very state specific basis. So that might be a place for folks to start if their state organizations are active. And I do see that GTMRX was shared as a resource as well, which of course I would heavily encourage everyone to sign up for and kind of get a wealth of resources that come through that can be supportive for that as well.
Right, thank you. So we have another question. Curious if any panel members can comment. It seems that most gains in states-based efforts are focused on fee-for-service billing. What examples are there of progress in pharmacist financial justification in value-based capitated payment models?
Can comment on that. I see that Starlin highlighted Minnesota as a state that's done a lot of value-based contracting, and those value-based contracts are usually negotiated between the health system or a network of pharmacies and the plans directly. I'm not aware of any really legislative or regulatory language at the state level that gives a lot of specifics about value-based care. But we know that between star measures or other quality metrics that a plan may be held responsible for, that they often welcome ideas of how can you help us reach our goals so that we make money, and then we'll share some of that back with you. So understanding what drives the regional plans in your area, as well as what's driving national plans with star ratings, is really important to start those conversations.
Thank you. All right, so we have in Texas, RPHs are recognized as providers for commercial plans. Is there a published roadmap or guide for us to share with our billing department so they can push for us to be recognized as in-network providers?
So I know ASHP does have a bulletin on some of it, and I can drop that into the chat.
Okay, so then we have a comment with a question beneath it. So the comment is pharmacists in the state of Washington are also recognized as providers and able to bill and are reimbursed for our services for both Medicaid and commercial insurances. And then the question was, has this translated to real-world financial justification and support for AmCare pharmacists in most practices? If so, what kinds of pharmacist population ratios are you seeing in practice? So was this a question that was for Carolyn Wong, or would you like for the panelists to answer it, Bradley?
Either way, I'm just curious to see what actually happens in the real world when we see things like, hey, pharmacists can bill in Washington State. That's awesome. Are there pharmacists in every clinic? How many pharmacists per group of population? That kind of thing.
Yeah, that's a great question, Bradley. And I see it as a huge step forward in terms of us being recognized as providers and able to bill for services. It's still a very unknown, I guess. It varies health system by health system, clinic by clinic. But I do think it has provided us some financial justification as AmCare pharmacists. and has justified us being in the clinics. I feel my health system is like all I can really speak to, but we are growing our AmCare pharmacy services based on some of this financial justification. But it does, there still are challenges. For instance, my clinic is a teaching clinic that has a huge Medicare population. So I can bill for my commercial and Medicaid patients, but a big portion of my population is still Medicare that I can't bill for. So that's kind of a hamper. And I can also see in terms of a challenge that we're getting some pushback from our medical group in terms of our slot utilization and how many patients we see per day. So kind of some of those same stresses that providers have in terms of seeing a quantity of patients to bring in that reimbursement. So yeah, so there's some challenges, but overall, I do feel like it's a big win for pharmacy, and it does allow us to really expand our services.
Dr. Chaudhry, I think you are muted.
Thank you so much for seeing my mouth moving. So I'm not from Washington, but I have collected data and I've been super intentional on it. And so we're in the process of publishing, but what it has translated to, being able to bill, is that for every half day of a clinical pharmacist being able to bill, it has increased the provider's revenue by 20%, which in turn has led to hiring more clinical pharmacists for every single clinic within that system. And I think it's really important to also supplement that with clinical outcomes as well to show that not only are we improving financial outcomes, but also clinical outcomes. But I do think one thing that has been a barrier is also protecting the setup of like what a pharmacist does. So, for example, if we focus just on financial aspects, like are we going to be forced to have shorter appointments and more frequent appointments because we're focusing on, making more investments and more money? But sometimes having like 30-minute slots for patients really helps build that rapport, and you're able to learn a lot of things that the provider can't because oftentimes they have 15 to 20-minute appointments. And so what I've seen is it's this weird balance of trying to figure out how do you bring enough revenue and justification to build the team while also protecting what makes us special as clinical pharmacists and why our outcomes are so positive in addition to providers seeing their patients by themselves.
Okay. So I think there's also some commentary in the chat that's focused around this question as well. Moving on, so we have another question, and it is, if different payers will reimburse differently, such as allowing 99215 billing reimbursement of pharmacist, how has your organization handled potentially billing different insurers using different codes for the same clinical service? This is problematic per our rev cycle department.
It's a really important question, Emily, and it's critical that you talk with compliance within your own institution because there are variables that impact how that is interpreted across different organizations and what their individual compliance department says. I will share that I heard recently from a health system in our state who, since we passed coverage for pharmacist services in Minnesota, we've had MTM covered for Medicaid for almost 20 years now, but a broader expanded coverage for pharmacist services under commercial plans. Some of the commercial plans were saying, yeah, we'll accept the M code billing, whereas some of the other plans who had already rolled out MTM as a commercial benefit said, no, we really want to use MTM CPT codes. That some compliance departments have said, okay, we know we're providing the same service. we're billing in the way the plans are asking us to bill. We didn't actually make the choice. You're telling us how you want to receive that bill. That's just one example in perspective, but you always have to go back to your own compliance office and try to keep giving more information to make sure they understand the whole picture when they're making that interpretation. But I've heard that from a lot of systems where there's sometimes this reluctance, and you've got to follow their guidance, but there could be interpretations that would be helpful.
Okay, thank you. So I think we have time for two more questions. Our next one is, can anyone speak to financial justification in specialty clinics that aren't specialty med dispensing based, but based on clinical services?
I think a lot of our panelists are in primary care clinics. I don't know that it needs to be different. You're caring for a different population, but the service is the same. So the allowance for billings should be the same, whatever that is allowed within your state. I don't know if others on the call might be in specialty clinics, but sometimes the specialty med dispensing might help fund it within a healthcare system, but that doesn't have to be the case.
Okay. So I think that might be all the questions, actually. Are there any last questions? I'll give it that 30 seconds.
I
All
was just
right.
gonna I was gonna clarify the question about the specialty meds. Most specialty providers feel that a lot of the value-based care metrics are none of their business, which whether or not that should be the case or not is a different conversation. But we've had a lot of trouble in my state where we don't have any ability to do fee for service billing, that the specialty clinics providers don't see any like value in the pharmacists impacting the value-based metrics.
That's tough, Jordan. I think we're slow to respond because that's just really tough. How do you help change the perspective of the specialist providers that we all want to ensure that our collective interprofessional care meets value metrics, and how does the pharmacist add to that? Perhaps with the specialist provider pool, focusing on other areas of the quadruple aim, maybe focusing on that provider wellness. How does having the pharmacist on the team help take some of the administrative burden off the specialist? If the pharmacist is helping to manage appropriate medication choices, that's aligned with formulary, and that's part of the comprehensive care you're providing. That may be a different target to help get the specialist providers on board. Just find out if value metrics isn't what speaks to them, there's probably something else that pharmacists can provide that would help speak to them and get them on board.
All right. Well, I'm going to pass it to Reagan at this point. Thank you so much.
Thank you all to our incredible panelists. This was such a wonderful presentation and discussion, and with a robust Q&A, you know that people were engaged and excited about this conversation. So I appreciate all of your hard work at putting this off. For those of you in the audience, this was a recorded session, so it will be available on YouTube and other platforms. And on behalf of the Ambulatory Care PRN Committee's Education and Advocacy, we thank you all for attending. Yes, love the virtual applause. Thank you, ladies.